You asked me to talk about the development of minimal extraocular surgery for repair of a retinal detachment over the last 50 years. This procedure, segmental buckling without drainage, was already introduced in 1953 by Custodes, a German in Düsseldorf. This procedure was great because it didn't have intraoperative complications, and so it was accepted with enthusiasm in Europe and in America. People did the procedure. However, in 1960, already the Skepens group reported about serious postoperative complications, consisting in endophthalmitis, perforation, and finally enucleation of the eye. This threw off everybody to do this procedure in Europe and in America. Not everybody in America. There was Harvey Linkoff in New York. He also had complications, but he was convinced of the rational approach of treatment. And he was thinking to do something to eliminate these complications. He replaced the polyviol plumb, which was not so tissue inert, by the sponge, and the diathermy, which necrotized the sclera, by cryosurgery. Cryosurgery was reported about in 1933, but it was not done and accepted in our surgery. And now Linkoff had introduced cryosurgery, and the people were saying, cryo doesn't make a scar. That's not possible, we cannot do this procedure. At that time, in 1969, I came to New York. I was already doing retinal surgery and had done electron microscopy, and I came to New York and I did over 3 years, 336 animal eyes treated with cryosurgery to test with pulling experiments the strength of the cryosurgical adhesion. We applied light lesions, medium lesions, and heavy lesions. The light lesions made a lighter adhesion. The medium lesion, just the blanching of the choroid, made a stronger and strong enough adhesion, and the heavy lesion made a stronger adhesion. And what was important, we could find that after 7 days the adhesion is strong enough and it increases in strength up to 12 days. So the procedure didn't have any more the postoperative complications. We had the sponge instead of the polyviol plumb and the cryosurgery instead of diathermy. People did the procedure. However, non-drainage did not work. Why? People didn't find the holes. And so Linkoff, being convinced of this procedure, he analyzed 1,000 preoperative careful drawings prior to surgery, together with Gieser, and he could define 4 rules how to find the break in a primary detachment. And the location of a break in a detachment he could define to be located within 1.5 to 3 clock hours beneath the superior border. Recall, a detachment caused by a break has convex contours and convex surface. And the next question was, can you not also do this minimal surgery for an eye which is up for reoperation? I would say yes. Why? When the contours are convex, it's caused by a break. And we analyzed, who likes to analyze failures, we analyzed 852 detachments we had treated with segmental buckling. There were 87 failures. And you would be surprised, in 80% it was due to a hole which was not found, and we looked careful for holes preoperatively, or a hole which was not tamponated adequately. So Linkoff and Kreissig, who established also 4 rules for an eye which is up for reoperation to localize break within a very limited period of the retina. That means we didn't have to do a cerclage. So this procedure was now successful. However, people were saying, how can an eye remain attached if you only treat a break, being so tiny, with a tiny buckle and nothing else? A cerclage is a better solution. We do security around the eye. I was convinced of this procedure, and therefore I decided to do a 15-year-long follow-up of 107 consecutive detachments. We had operated with segmental buckling, minimal surgery without drainage. And how were the results? After one operation, the retina was attached in 93%, after reoperation in 97%. However was the long-term follow-up? If the retina was 6 months attached, we could certify and find out that after 6 months the retina, listen, detaches only in 0.5% per year over 15 years. That means, with other words, if the retina is once attached, you have saved the eye, it stays stable. And the next question was, all right, if the retina remains attached with this minimal buckling for 15 years, how is it with the regained visual acuity? Perhaps this might change over the years. Okay, we analyzed. We found out that the maximum of visual acuity increase we have in the first 6 months, up to 1 year. And you will be surprised. We were surprised. In the subsequent years, from 1 year to 15 years, there was a slight decrease of visual acuity of 0.07 line in the Snellen's chart per year. My God, was this the reason, the buckle? No, we have 2 eyes. We compared it with a fellow eye which had no buckle in place, and there was the same slight decrease over 15 years, and there was no statistical significant difference between these 2 eyes. And in addition, we have the data of Zlatteper, who analyzed and followed up the visual acuity of 17,349 individuals over lifetime, and he had found out that after the age of 60 there is a slight decrease of visual acuity, and this slight decrease coincides with a slight decrease we had observed in the operated eye with the buckle in place and in the fellow eye. So this decrease was due to aging. Now, you have 4 procedures to treat a retinal detachment. You have segmental minimal buckling without drainage, you have pneumatic retinopexy, you have the cerclage, and you have the vitrectomy. What to do? It is up to you what to select. However, be always aware, whatever detachment surgery you select, by this you determine the future of the eye. And now recall, minimal segmental buckling you can use in over 9 of 10 cases. In over 9 of 10 cases, in 97%, the retina remains attached over 15 years. And in a bigger meta-analysis of Lidkov for 1,854 patients, he found out that in this big series of minimal segmental buckling and balloon operation, over the years, the rate of reoperation was in the first half year 9%, 9.1%, and the PVR only 0.9%. Now, which surgery to apply to the benefit of your patient? I will try to help you. I would say there are 5 requirements. The first is, the surgery you select should reattach the retina after 1 operation. Secondly, you should select and do a surgery with a minimum of morbidity, almost no morbidity. Third, when the retina is attached and the visual acuity in the time to come should not be jeopardized by secondary complications such as glaucoma or cataract. And fourth, the surgery should be done in local anesthesia because your patients are over 60, 70, 80 years of age. And fifth, I think that's almost the most important, you should do a surgery on a small budget. Why? We have now excellent treatments for AMD. Many patients who get older get AMD. And this treatment has to be repeated very often and it's very expensive. And you know, the money we have for ophthalmology is limited. So you have to think about what to do your patient. And when you think about these 5 requirements, which surgery might fulfill these requirements? I would say minimal extraocular surgery with a good, determined, confirmed long-term reattachment rate and good long-term function, I think might fulfill these requirements. And in surgery, I even would conclude for you, less surgery makes less complications and makes more long-term visual function. And I would say it's the same as in art, which developed over the centuries. In art, if you think of the suprematist, the slogan is less is more. In surgery, less surgery is more for long-term function and the benefit of your patients. And I would like to transfer this to you to remember when you treat a primary retinal detachment. Thank you to listen.